Hello, my name's Casey. I'm going to be talking to you guys about Boutonniere deformity. Boutonniere deformity is something that I was pretty unfamiliar with up until this point, so I hope you guys are as interested in it as I was. Alright, so Boutonniere deformity is the result of an injury. It can also be caused from osteoarthritis or rheumatoid arthritis to the tendons that straighten the middle joint of your finger. When this occurs, the middle joint of the injured finger will not straighten while the fingertip bends back. So if you can see in the picture in that right hand, the right hand of the slide, you can see that the PIP, which is going to be your proximal interphalangeal joint, is going to be flexed, and then if you look at the DIP, which is going to be your distal joint, you're going to see that that's hyperextended. If this injury is not treated promptly, the deformity may progress, resulting in a permanent deformity and impaired functioning. So this is going to be a deformity that you're going to want to address immediately. You're going to want to refer it to possibly a surgeon if you think that splinting is not going to be adequate, or you can also do also going to be referred to a rheumatologist as far as it's contributed to rheumatoid. So the PIP permanently bent towards the palm, while the farthest joint, the DIP, is hyperextended. Clinical manifestations of this deformity include painful and swollen. It's going to be painful and swollen around the PIP joint, so that's going to be that middle joint in your finger. You're going to be unable to straighten the finger at the middle of the joint, and then you're going to be unable to bend the fingertip down, so the DIP. This deformity is categorized into 5 stages. As you can see, the progression of the deformity is going to be worse off as the stages go up. So stage 1 is going to be your active extension of the PIP may be weak in the slightly flexed position. Active extension is possible with lateral bands in normal anatomic position. Stage 2 is going to be a triangular ligament weakened with volar shift of both lateral bands. An active extension of the PIP joint is affected. Stage 3 is when you're going to start to see your progression hyperextension of the DIP joint with active and passive flexion, and active and passive flexion is going to be limited. Stage 4 is going to be... Pat, turn that down! Pat. Pat.
What?
Can you turn that down?
Huh?
Can you turn that down?
Go down?
Yeah.
Okay.
Stage 3 is going to be your progressive hyperextension of the DIP, and then stage 4 is going to be a fixed flexion contracture of PIP joint because of volular plate, and stage 5 is going to be your articular degeneration of the PIP joint. So some differential diagnosis and diagnostics that you would do with this deformity. The swan neck deformity is one that we see probably more common, more often. This is the one I was more comfortable with and more familiar with. But with the swan neck deformity, you have PIP hyperextension, as you can see, and then DIP flexion. So it's literally going to be opposite of Boutonniere's deformity. And this is going to be important to know because when you do have someone coming in with a deformity, you're not going to want to give them a diagnosis of a swan neck when it's Boutonniere's and vice versa. Some diagnostics of this deformity are going to be physical examination and x-rays. Physical examination is going to be pretty standard. You're going to be able to see the obvious hyperextension and the flexion, and be able to tell, and hopefully be able to tell the difference between the swan neck deformity. And then x-rays are going to be necessary when you think that there might be a fracture present, and for surgery purposes. No other tests are really required. They didn't say anything about any MRIs or any anything other than those 2 diagnostics. So treatment for this deformity would include non-surgical and surgical options. So non-surgical is obviously the more preferred option in most cases. It may include splints, which is applied to the finger at the middle of the joint to straighten it. This allows the end of the tendons from separating as it heals. It doesn't allow the end joint of the finger to bend. It does allow for the end joint of the finger to bend. And you're going to want to wear that continuously for 6 weeks if you're a young patient, or 3 weeks if you're an elder. So it's going to allow that those it's going to allow those tendons to heal, and then keeps it from separating. Some treatment continued. Exercises, you're going to want to have the patient stretch, practice stretching their fingers to improve flexibility. Also, protection, might possibly have to wear protective splinting or taping for several weeks after the splint is removed. So even along the 6 weeks for a young patient, you might have them do some taping or some additional splinting just to protect that finger from getting a permanent contracture or permanent deformity. If the deformity is caused by arthritis, it may be treated with oral medications and corticosteroids injections as well as splinting. So this is also when your rheumatologist is going to come into play. If it is from RA, DMARDs, getting them on some injections might be necessary. Surgical options. Surgery is an option when the deformity results from RA, the tendon is severed, a large bone fragment is displaced from the normal position, or the condition does not improve with splinting. And those are going to be pretty, those would not be helped with non-surgical options. So surgery would have to be an option. Joint fixation is something they might do where they place a pin through the PIP joint. Soft tissue repair where they reconstruct and rebalance the extensor hood. And then fusion, they might do a finger joint fusion where they joint surfaces together, eases pain. So they fuse them together so it prevents bending. The expected role of the nurse practitioner in this case would be safety education and prevention of hand injuries, especially in the younger adult. If you've got somebody doing a lot of sports, definitely prevention of hand injuries because this can be caused from a finger injury. Education of splinting and exercises to promote function and progression of the deformity. So a lot of education as far as keeping the splint on for the full course, the 6 weeks, the 3 weeks, and then post exercises after the splinting, taping. You're just going to want to readdress. You're going to want to readdress all of these points. Refer to an occupational therapist to design an exercise program. That's going to be working into the finger exercises. Prescription of DMARDs, and that's going to be your rheumatologist if RA is a factor. So we've got a case study here. We've got an active 18-year-old woman who is unable to straighten her finger after a blow during a game of netball on the weekend. It is causing her a great deal of discomfort. The middle joint of the injured finger, which the PIP will not straighten, while the fingertip bends back. So as you can see, she's got visualize, she has the PIP flexed, and then she's got the DIP hyperextended. So right there, that rules out the swan neck deformity because that's going to be the opposite. So her vitals look good. No allergies, no medical history. She takes the daily women's multivitamin as medication. And then your physical exam. The PIP is bent towards the palm while the DIP is hyperextended. Tender on palpation of the joint of the DIP and the PIP joint, and they are swollen. So diagnostics, an x-ray was completed to rule out fractures along with physical examination. So the x-ray was done because of a finger injury. You're going to want to check for fractures, and then a physical examination where you can see the flexion and the hyperextension is going to give you your diagnosis of the Boutonniere's deformity. And no fractures were seen in her case. Diagnosis in this case is stage 3 Boutonniere deformity based on the examination of fixations in the finger joints. So if you remember from stage 3 is going to be where you're going to see some hyperextension of the DIP with active and passive flexion limited. She started to have some limitations in her finger flexion. So the treatment in her case was splinting for 6 weeks with referral to an occupational therapist for finger exercises, and obviously some education from the nurse practitioner on importance of protecting finger and preventing injuries, and looking at the progression of the deformity. We would see if additional splinting or additional taping would be needed after the 6 weeks. So a reflection on this deformity and this project. I thought was that it was more difficult to diagnose, in my opinion, because of lack of information about this deformity. It is not as common as you would think. I did not find a lot of research, case studies, advanced nurse practitioner questions available. So it was one that was a little bit more limited. Definitely not as open with information as a swan neck deformity. Like I said, case studies were hard to find on this deformity, and research was limited. More nurse practitioners need to be educated on this topic. I think so. I'm sure I'm not the only one who didn't hear about this deformity all that much. The swan neck, like I said, I was very familiar with this one, not so much. So I think that stressing this topic would be important. A thorough assessment needs to be completed with finger injuries. I definitely thought so after reading this case, or reading about this deformity, just because if you don't want to do a wrong assessment and a wrong diagnosis and have this end up to be a permanent contracture and a permanent deformity, because this seems to be pretty influential as far as being able to conduct your EDLs. You know, your fingers are going to be your, everything. You do everything with them. And like I said, this diagnosis needs to be able to be distinguished from the swan neck deformity and RA. So, like I said, just to be able to tell the difference between this deformity versus a lot of other hand deformities and fractures. And that is going to complete my assignment and PowerPoint. Thank you very much.